In this class, we'll try to learn about blood glucose homeostasis. Blood glucose regulation within its normal range is due to effective feedback control mechanisms that operate to regulate metabolic processes in the body. In spite of disturbance and fluctuation of blood glucose by various physiological and non physiological processes and stimuli, blood glucose is maintained within a strict range. The blood glucose homeostasis is the reflection of good health. Normal fasting plasma glucose is around 70 to 99 milligrams per deciliter. After food intake, this value increases but remains within 200 milligrams per liter range. Therefore, random blood glucose when less than 200 milligrams per deciliter is considered normal. The normal postprandial 2 hours of blood glucose level is less than 140 milligrams per deciliter. So these are the blood glucose levels in normal and impaired and in diabetes mellitus. Okay, so these can be fasting, postprandial, and random. In normal, it ranges from 70 to 99. Postprandial less than 140. Random should be less than 200 milligrams. In uh, impaired fasting glucose is when fasting is ranges between 100 to 125. Impaired glucose tolerance is called as when postprandial blood glucose within the range of 140 to 99 milligrams per deciliter. And diabetes is when fasting is more than 126, postprandial more than 200, and random blood sugar more than 200 milligrams per deciliter. So, blood glucose is maintained by mainly the hyperglycemic hormones like glucagon, epinephrine, cortisol, growth hormone, thyroxine, and hyperglycemic factors are absorption of the glucose from GIT, hepatic glycogenolysis, neoglucogenesis, and some of the hypoglycemic hormones are importantly insulin and hypoglycemic factors like glycolysis um, uh, by the TCA cycle and glycogen synthesis and lipogenesis. Deficiency of insulin results in diabetes mellitus. Diabetes mellitus is the most common endocrine disorder of mankind. India has become a global epicenter of diabetes. Every 1 in 3 in urban and every 1 in 5 in rural population are found to have a latent glucose intolerance or frank diabetes mellitus. Change of lifestyle, easy access to the food, that is increased calorie intake, junk foods, sedentary lifestyle, and environmental factors and stressful life are among the causes of such spurt in diabetes in India. In human beings, diabetes occurs usually due to destruction of beta cells of pancreas or due to decreased sensitivity of insulin receptors to insulin. Diabetes is a state of starvation in the midst of plenty. In untreated diabetes, plasma glucose concentration is always high. In spite of hyperglycemia, the tissue cannot utilize glucose either due to insulin deficiency or due to insulin resistance. In this condition, cells cannot utilize glucose though they are surrounded by high concentration of glucose. Therefore, diabetes is called as disease of starvation in the midst of plenty. Classification. Uh, Type 1 diabetes mellitus. It is associated with a profound insulin deficiency and requires insulin replacement therapy. Earlier this was called as insulin dependent diabetes mellitus. Type 2 is associated with normal insulin levels in plasma and patient is usually treated without insulin replacement therapy. Earlier, this was called non-insulin dependent diabetes mellitus. However, recently it has been observed that more than 25% of the diabetes mellitus ultimately develops insulin deficiency requiring insulin replacement therapy. Therefore, classification of IDDM and NIDDM has become obsolete. So this is etiological classification of the diabetes mellitus. It can be insulin dependent, insulin resistant or deficient, or other specific types of diabetes mellitus. Okay, so insulin deficient can be immune mediated, non-immune mediated. Insulin resistant or deficient can be polygenic or monogenic, where in polygenic you have insulin resistance or pancreatic beta cell failure. In monogenic, it can be maturity onset diabetes mellitus, latent autoimmune diabetes of adult, or permanent neonatal diabetes mellitus. Other specific causes could be pancreatic diseases, exogenous or excess endogenous production of insulin antagonists. For example, the growth hormone excess secretion, that is acromegaly, Cushing syndrome, pheochromocytoma, etc. It could be drug induced or viral infections or genetic syndromes. Okay, and at the end, it can be because of the gestational diabetes. Major types. Type 1 is characterized by insulin deficiency, which is usually caused by selective autoimmune destruction of beta cells of pancreas. Therefore, the disease has traditionally been called insulin independent diabetes mellitus, that is IDDM. The disease starts with insulinitis. Many patients demonstrate antibodies against beta cell uh, surface antigens. If one of the twins develop the disease, the other twin has a more chance of developing the, the disease than the people in the general population. That is, concordance rate is less than 50%. The disease usually starts early in the childhood, and ketoacidosis is common. Type 2 diabetes mellitus is characterized by impaired ability of the target cells to respond to insulin. This is usually caused by insulin receptor resistance. The insulin secretion may be normal or even more. Therefore, the disease has traditionally been called as non-insulin dependent diabetes mellitus, that is NIDDM. The chance of identical twin developing the disease concordance rate is 100%. The disease is usually starts late in third or fourth decade of life. The patients are usually overweight and sedentary in their habit. Feeding habit and environment also contribute. Chronic stress is usually associated with it. Usual complications is hyperosmolar coma. Oral antibiotic drugs are usually preferred for the treatment. However, insulin may be prescribed. So these are the major difference between type 1 and type 2 diabetes mellitus. So type 1 is before the age of 40, so it is also called as juvenile onset diabetes mellitus. So type 2 after the age of 40, so it is also called as maturity onset diabetes mellitus. Body fat, they are type 1, they are not obese, but type 2 they are obese. Type 1, 10% of the total diabetes. It is type 2 is 90% of the total diabetes mellitus. Concordance rate is here 50%, here it is more than 50%. Incidence of ketoacidosis high in type 1, low in type 2. Beta cells are destroyed in type 1, beta cells morphology is normal in type 2. Nature of onset is rapid in type 1 and gradual in type 2. Ketoacidotic coma is common in type 1 and hyperosmolar coma is common in type 2. Maturity, ons, Maturity onset diabetes often constitute about 5% of all cases of diabetes. This is the form of type 2 diabetes in younger individuals. 11 types of MODI have been described, 1 to 11. Most common among them is MODI 3 that occurs around 20 to 75% of all MODIs, and MODI is the next common. MODI 3 occurs due to the mutation of HNF1 alpha gene, the gene for hepatocyte nuclear factor 1 alpha. Patients with MODI 3 are mostly in their adolescence and diabetic complications are frequent. But they have a greater hypoglycemic response to sulfonylureas than the patients with type 2 diabetes mellitus. MODY2 is the next common group that occurs due to the maturation glycokinase gene. They present with a mild hyperglycemia from the birth, but they are stable and managed by diet alone. The other forms of MODY are less common. Secondary diabetes mellitus. This occurs due to the disease of pancreas like pancreatitis or following pancreatectomy. Diabetes can also occur in Cushing syndrome, that is, cortisol increases plasma glucose, and acromegaly, growth hormone, increases plasma glucose. So, these forms of diabetes are included under the category of secondary diabetes mellitus. So, this category constitutes about 5% of the total diabetes. Gestational diabetes, this refers to hyperglycemia occurring for the first time during pregnancy. 80% of the women with gestational diabetes develop uh, diabetes postpartum. Features. Diabetes mellitus is characterized by polyphagia, polyuria, polydipsia, weight loss in spite of increased food intake, hyperglycemia, and glycosuria. If not treated, the disease leads to ketosis, acidosis, and coma. In chronic cases, there may be diabetic retinopathy, neuropathy, or nephropathy. Glucose entry into the cell in the brain, except in the ventromedial hypothalamus, which is independent of insulin. Thus, VMH depends on insulin for its glucose uptake. VMH is the satiety center that normally inhibits the lateral hypothalamus, that is the feeding center. As VMH depends on insulin for glucose uptake and utilization, insulin deficiency in diabetes decreases the activity of VMH. Decreased VMH activity removes its inhibitory effect on uh, the LH, and therefore LH activity increases due to disinhibition, that is abolition of inhibition from VMH. So there occurs facilitation of the feeding center because of the increased LH activity increases the feeding, so that leads to polyphagia. So this diagram showing the same. So when the satiety center, because of the diabetes mellitus, uh, the glucose does not enter, inside the cell. Okay, so the satiety center is not stimulated, which usually when it is satisfied, it inhibits the feeding center. Uh, so that causes the feeding center to be stimulated, and that leads to excessive feeding. In diabetes, the plasma glucose concentration increases above renal threshold, that is above 180 milligrams percent. Glucose appears in the urine. Filtration of more glucose increases tubular load, and increased concentration of glucose in the tubular fluid causes osmotic diuresis that results in polyuria. In diabetes, because of polyuria, water is lost in excess from the body. This decreases the plasma and ECF volumes. Dehydration stimulates the thirst center that causes polydipsia. So this is mechanism of development of the coma in diabetes mellitus. Insulin deficiency leads to increased proteolysis, increased plasma amino acids, uh, and loss of nitrogen in urine that leads to dehydration and acidosis. And decreased glucose uptake and utilization and increase production of glucose leads to hyperglycemia and glycosuria, and polyuria and electrolyte loss that ultimately leads to dehydration and cellular dysfunction, and enhanced lipolysis will lead to ketonemia and ketonuria, acidosis and diuresis. So ultimately these factors will lead to coma. Diagnosis of diabetes is done by demonstrating the persistent hyperglycemia and glycosuria. estimation of fasting and postprandial blood glucose is performed to demonstrate hyperglycemia, and estimation of glucose in urine is carried out to demonstrate glycosuria. So this is done by GTT, estimation of fasting blood glucose, and estimation of the glycated hemoglobin, that is HbA1c. So this is how you should diagnose the diabetes mellitus based on the fasting blood glucose, postprandial, and HbA1c. So normal glucose, if uh, should be within the 70 to 99 milligrams percentage, okay, and it should be less than 140 milligrams per deciliter, and HbA1c should be within the range of 4 to 5.6%, whereas impaired fasting is when FBS is within the range of 100 to 125, and uh, the postprandial between 140 to 199, where HbA1c is between 5.7 to 6.4%, whereas diabetes is diagnosed when fasting blood sugar is more than 126 or more, or postprandial more than 200 or more, uh, and when HbA1c is more than 6.5%. So this is a response of oral glucose tolerance in normal and diabetes. Note that the plasma glucose level remains always above the normal GTT value in diabetes patient, and does not come into the normal range of plasma glucose. Treatment. Insulin replacement is the cornerstone treatment for type 1 diabetes mellitus. The maximum decline in plasma glucose occurs following 30 minutes after IV injection of crystalline insulin. Insulin is also injected subcutaneously, but decrease in the plasma glucose concentration occurs in 2 to 3 hours. Different types of insulin preparations are commonly available. Generally, insulin preparations are divided into three categories depending on their duration: rapid acting, intermediate acting, and long acting insulin. Oral hypoglycemic drugs, sulfonylureal derivatives like tolazamide, glipizide, gluburide, etc. These drugs are usually prescribed for the treatment of type 2 diabetes mellitus. The other oral hypoglycemic agents are biguanides, that is uh, fenformin and metformin. Metformin acts mainly by decreasing gluconeogenesis, therefore, it decreases the hepatic glucose output. The other group of drugs like thiazolidinones, that is troglodyazone, is an example in this group, is also used. They increase insulin mediated peripheral glucose disposal. Hence, they decrease insulin resistance. So, that is why it is used in NIDDM. Troglodyazone also binds with peroxisome uh, proliferato activated receptors, that is PPARG, in the nucleus of the cell. In addition to the drugs, it is important to assure lifestyle modification and proper calorie intake in the long term management of diabetes mellitus. The food intake should be adjusted to ensure appropriate nutritional requirements. Excess intake of the food should be avoided. Diet should have a less carbohydrate and fat and more fibers and adequate proteins and vitamins. Regular exercise, morning walk and freehand exercises improve insulin release and decreases insulin resistance. Relaxation of the body and mind, healthy body and mind without stress will not only cure diabetes but also prevent the other diseases. Complications. The microangiopathy causes retinal edema and scarring, which is often associated with hard exudates in retina. So this condition is known as diabetic retinopathy. So which also can occur due to the neurovascularization of the retina, especially in advanced stages. The microangiopathy in the kidney is also known as diabetic nephropathy. The macrovascular complications are primarily due to the increased atherosclerosis. Atherosclerosis is accelerated due to the increased plasma LDL. So this increases the incidence of heart attack, that is myocardial infarction and stroke. Autonomic nervous system and peripheral nerves are also involved in the disease process. So this results in autonomic neuropathy, that is also called as diabetic neuropathy. Hyperglycemia and neuropathy decrease the resistance to infection. So this results in chronic ulcer, gangrene, and formation, especially in the foot, is called as diabetic foot. So this is the fundoscopic view of proliferative diabetic and retinopathy in chronic diabetes. So note that there is a prominent neovascularization of the retina and dot plot hemorrhages and hard exudate in the macula. So this is in brief about uh, the glucose homeostasis, diabetes, and the treatment of the diabetes. Thank you.